I have the most cool job, I think, in the country now, which is I get to be a venture capitalist and like get to see the stuff that you've already sorted for me, so thank you. And then invest the money to make it go further. And I get to play around in policy in my spare time and write papers about how to make healthcare better sooner. And so I have the awesome chance tonight to first say that everything you just heard is true. So I can't believe what a good primer that was. It took me a lot more pain than what you just had to go through to learn everything that you just heard from Ash, and develop the don't do ever again list that you'll all develop as angels. But I'm going to talk about why it is awesome to be an angel healthcare investor. The timing is right, that you will have fun, and while it may be being a patron to the arts, it's probably a good thing for America. So first, what the heck is digital health investing? This is my definition. And I want to emphasize a couple points to it for you. It's technology that decreases healthcare costs and substantially improves healthcare quality. You need to think really big here. Our health system is so friggin' expensive that if you can't invest in something that makes it a lot cheaper, it's not a good idea. Our health system is actually so uneven in how care is delivered, and there's like 35 doctors in this room. You know, what happens to patients is so uncertain that if you can't invest in something that makes patient care a lot better, it's probably not good enough in terms of being better enough. And so I would urge you to look for not incremental, but rather shockingly large benefits. Why is that? Because anything you see has been proven like in some tiny experiment, and it never works as well at scale. And so if it's not having a dramatic, unbelievably obvious difference in either cost or quality at the point you're investing, it's not going to have one later. Moreover, our health system is so uneven and so clunky and so messed up that if you can't manage to find some of the $800 billion of waste that we find that happens every year in your investment and capture it for value for both its customers and patients in America, you're probably not doing a good thing. And on quality, I mean, we need to have more imagination. So for me, when I'm investing, an investment has to make healthcare more affordable. It has to make quality better. And basically, the mantra I use is better sooner. And is it going to do enough? But if you don't have an ROI in the thing, you should seriously question why on earth you'd make the investment, because customers at some point will do it. If the investment's predicated upon a reimbursement quirk, you're making a big mistake, because my friends at Medicare are actually smarter than you think, and health plans are smarter than you think. Markets and patients are happening sooner than you think. If it's predicated upon reimbursement changes that haven't occurred yet but might in the future, for Christ's sake, don't guess the timing. So don't front run that, would be the other advice to you. And so with that, let me jump into how we at Venrock and I look at what gets me excited, with the hope that that will get you excited and help you maybe calibrate to what we might want to find at the A round and beyond. So you don't end up with sort of these seated but never moving forward ideas. This is a lovely picture of Shanghai. I update it, by the way, every time I do the pitch because the skyline changes. It's very important because China is why our interest rates are low. California got upgraded today, by the way. Good for California. We're now at the A level of junk bonds. This is China because I want to give you a sense of scale. We spend more every year in the US health system than China spends on everything. Even better, we're growing faster. So the US health system is growing faster than the Chinese domestic economy. Back to this is a big friggin' market, which means you better find economic value in it. And that would be totally good news, except for the fact that all your wages, even doctor wages, have gone to pay for your health care, not to your cash. It'd be great if we were getting better, so we were getting a higher ROIC on that invested capital as a country. It'd be great if American wages could afford to spend $20,000 on a $40,000 median wage, but that doesn't work. But here's why it's not great, is that we don't get enough value. We don't live happier, we aren't living healthier, and we duke it out with Cuba and Slovenia on the league tables for anything you want to measure in our health system, only being better for preterm labor and cancer diagnostic screening when we pay for imaging. Otherwise, like, we aren't getting a heck of a lot of value. Now, our hospitals look a lot nicer than Cuban ones, but the chances that the doctor washes their hands here are equal to that in Cuba, if not a little worse. So I would urge you to be thinking about quality. And you are doctors, like, you've all seen this, but you know it. Like we aren't as awesome as we would have hoped. But here's the real problem. This is the only sector in the American economy that every year manages to destroy labor productivity. Big investment theme, guys. So healthcare every year for the last 20 years has destroyed 60 basis points of productivity per year. The only reason our economy is big, great, strong, awesome, and America is that we actually have more labor productivity everywhere else than the rest of the world. That's our secret. Europe hasn't figured it out. Asia hasn't quite figured it out. It's still more labor. We get more productivity. This Great Recession was a big productivity boon to America, but not in healthcare. We destroyed productivity yet again. This means for every patient every year, it takes 60 basis points more people to get them to have whatever happened that happened last year. And here's the stark numbers. This is the ratio. This is beautiful numbers. This is the ratio of doctor to non-doctor FTEs in American healthcare. This is the change in the last 10 years. So there's 23 people jangling behind me now in America doing stuff that costs a heck of a lot of money and hasn't seemed to make outcomes different. When you unpack that number, it is astonishing. So it's roughly a third of them are home health aides, home health nurses, and stuff you could vaguely say is kind of care shifting from hospitals to outpatient and maybe like a patient-centered medical home, so maybe it's value added. A third of it is coding, collections, and revenue cycle, and the people that work in the building behind the hospital that harass you about your unfinished charts, and like the crappy stuff that's the help desk for the dictation, natural voice recognition software that didn't quite work, that didn't capture, that's that. And then a third is hospital administrators and practice administrator people that like look after the other third of the people that harass you. So, and this would be great because we need 22.5 million jobs in America to get to 5% unemployment, except for the fact that the $2.8 trillion we spend, roughly 70% of the money is salary and wages to workers. Healthcare workers are paid a lot. And so every time we add a worker, we add 70K roughly to the health system. And if we're going to add 30 million people to the health system next year with the Affordable Care Act coverage expansion, if we add that ratio of labor, we are screwed. Which means every hospital in the country who's not going to have reimbursements grow at the rate they've grown before is desperately looking for things to help them get labor productivity. Any of you who have a private practice office will be insane if you're not thinking about how to eke out some productivity and not hire another coder. Every health plan in the country is really interested in this because we've capped their profitability at not more than 15% by virtue of the medical loss ratio regulations. So they're very concerned about how do they get more productivity. Employers, for Christ's sake, are worried about productivity because they're losing a lot of it on the half day of work that every worker loses when they go to see you. And so this is the big theme I point out to you. Now, you know as doctors, those of you that actually see patients, like the 5 left in America, know that you can't see like another, you don't have like, you can't make the visits go from like 15 minutes to 12 minutes. Like, it's all about leverage. Like, how do you use non-doctor labor to do stuff? And how do you be smart about this? But this is going to be where billions of dollars are made. It's in figuring out how to get labor productivity in healthcare. Because we are expanding demand, and if the supply side has to expand labor to the extent that it has, at the rate at which reimbursements will grow, they will all go out of business. That's a really good opportunity for you. That's my rant on labor. We can talk about it more in the Q&A. This is going to get better, because actually it can't get a whole lot worse. So the Affordable Care Act is the externality that began the process of the health system coming to Jesus and realizing that we can't raise prices 8% a year forever because we'll run out of money. The second thing it did is it said, you know what? We can't have a system that doesn't cover 50 million people who need coverage. They're not all deadbeats. Some of them are hardworking young people. Some of them might have been you between jobs. Like there are people we care about. We have to cover them, so we need to find a way to do it. The third thing is we took the largest step humanly possible, but less than you may have hoped, about changing the reimbursement system from being purely fee-for-service, doctor activity-based, to hopefully something that rewards value and not just doctor activity. And this is a 10-year evolution, but we're on it, which commercial insurance plans will actually accelerate. The other thing it did is it caused employers to act differently. So a very important fact that you must always remember near the front of your head is that every dollar of profit in the American healthcare system comes from the commercially insured patient segment. Medicare is basically a break-even business, and Medicaid or Medi-Cal is a disaster. That's true in every state. It's basically true. And large employers who are the highest paying people in the American healthcare system have said, you know what? We don't really like that PPO network with 99% of doctors in it that sort of pays non-discriminately. We want to actually begin leveraging our market power. We might want to compete with you and build our primary care centers. We might want to narrow our network. We might want to do reference-based pricing. We might want to do transparency. We might want to, we might do full replacement high deductible. We might do defined contribution. All of the above reduces their exposure to medical inflation and moves market share out of the market and makes a hospital or a doctor incredibly sensitive, because a small difference in commercial patient volume is a massive difference in performance for a hospital or a doctor. And we're beginning to see the commercial employers change and commercial insurance companies change and make new benefit designs that are less sucky or maybe more engaging, depending on how you want to think about that, that is moving volume around the market. And when the high-paying customers start moving, the whole supply side has to change. The third thing that's really, really important is that the advent of healthcare insurance exchanges, which California will have one of the better ones soon, reduce switching costs. So suddenly, plans have to think through how to differentiate. They can't underwrite. And you will be able to change without having to go through the 6-month-long process of getting a bid. So that switching costs will make a much more consumer-centric market, one where differentiation is important, one where churn matters. Insurance companies have more or less become cell phone companies where they have to think through how do they create a product that's sort of different than Verizon versus AT&T. And so this is changing a lot on the demand and intermediation aspects of the system. But the second thing I'd say is that I think everybody realizes that with the fiscal cliff shenanigans and the debt ceiling debacles and the uncertainty in our demographics in America and what will happen to the US economy, is that there's another round probably of cuts to come if the Affordable Care Act does not exceed the CBO score for how much it's going to save. And different from the last decade, we actually have already written out, baked, published in the New England Journal of Medicine, the next set of things. So they're being socialized, scored, bipartisan groups are having think tanky discussions about these things. But they're basically this type of stuff. And so these are the 8 things that if you were to go ask the White House or the Senate Finance Committee, like, what's next? This is sort of the genre. It's things that look more like capitation, not fee-for-service. It's more competitive bidding. So not just any doctor, but saying, we want 1,000 colonoscopies in San Francisco, bid, and have certain bars for quality. Non-doctor clinicians, and maybe even cross state lines if we can be so radical. Less self-referrals. The notion about kind of trading consult for consult and owning the MRI and referring to yourself. Probably hospitals will at some point not be able to negotiate 20%, 30% higher prices for the employed doctors. So the doctors will have to have separate rates. Like we're going to go away from some of the collusion. I think finally med-mal reform, hopefully safe harbors for following evidence. Many more tiered products where there's hard limits on what you're going to get and who you can go to in insurance designs. I think we're going to see total liquidity around doctor quality information and much more individualized pricing data. And I think we will eventually get rid of some of the coders in the building and go to single claim forms and electronic submissions and denial rules that are transparent. This is the stuff that's sort of next up. I say this because if I were an investor, I would be pretty interested in administrative simplification because nobody is going to want to sort of have more coders in America. I would think a lot about transparency and market formation and how you create that. Bidding things around how do you bid volume and sort of pre-buy services. Non-doctor clinicians, I think, is a really interesting area. There's a heck of a lot. A non-doctor clinician does better than a doctor with a computer than a doctor does, or better than I did, for sure. And so I'd be thinking a lot about these things. I would also say it's really important for you as an investor to kind of be purposeful about where you're pushing on this balloon of the health system. So as a simple doctor economist, I like to think about it as demand, supply, and then there's all this stuff in the middle that sort of couples them, which are payers and these exchanges. I think the data is very clear that supply side is a big enterprise play. They feel really big cost pressure. They have really big needs to differentiate. And that's sort of the ethos of what's on their mind. On the demand side, it's much more about how do you create markets. There's huge arbitrage of price and quality. And how do you create markets that actually become more efficient? And on the payer and exchange side, it's much more how do you convert them from old school health plans into things that are as intelligent as either an airline or a phone. Pick your analogy, but how do you make them more like an airline or a phone company or a consumer-facing company? And what are the things that they need to manage customers instead of members and B2B relationships? And on exchanges, there's 1,000 things to do, and this is not the time to unpack all of them, but there's a lot of opportunities there. I am really optimistic that we're seeing real innovation in real companies being built in each of these areas. So these are ones that have all made it past the angel round, or to me. But on the demand side, the intermediate payer and exchange side, and on the supply side, to give you a sense of there's disruptive people who are being successful. And what I want you to remember here is that a really cool feature here is that mega companies, whether they are mega incumbent healthcare companies and health plans and hospital systems, or large employers, are now buying services from companies that weren't invented 2 and 3 years ago. And so the chance to grow fast now in healthcare technologies and services is better than ever before. It used to be you would spend a year begging Kaiser to do a pilot, and then they would spend another year doing the pilot, then the actuaries from Mathematica would spend another 6 months, and then Mark would fund a grant to do the next thing, and then Kaiser would say, we might do an RFP. Now, they will try stuff and buy stuff, and even invest. And every other major for-profit hospital system now has a venture group that wants to go outside to get R&D and try it. Health plans are buying startups. I mean, it is a changed place. I'm on the board of Castellet Health, which is one of the successful ones on the demand side, and totally different than what would have happened 10 years ago. We started with the mega employers, and then are working our way down as opposed to having to get little guys to take a risk and then work your way up. We're seeing big people want to do stuff. So that makes it a lot faster to build really important companies. On the insurance side, we are seeing startup insurance companies. SeaChange Health is a brand new insurance company that started in California, the first new insurance company, I believe, in 50 years in California, and now there's a couple more. In New York State, you're seeing startup insurance companies. You're seeing people actually really disrupt with new benefit designs, new ways of thinking, lighter, less administratively burdensome processes. You're also seeing really neat things around exchanges, around defined contribution, helping people select plans that actually meet their needs. A company I didn't put up because it's been acquired as Bloom Health, but another example of a company that helps you define contribution and make private exchanges. These are really interesting ideas. On the supply side, everything up there takes meaningful cost out of the system and has rethought how to deliver healthcare or support its delivery to get a bunch of labor cost out and massively improve the reliability of it. And you can see that in both the app and patient education layer, as well as the nurse productivity, as well as in the how to imagine primary care so it's not so painful. You can see it in kind of every way. And so I think you should have a lot of optimism that there's good ideas and they can grow quickly when they meaningfully take out cost and meaningfully improve quality. So these are the 5 questions that in my diligence and in my first conversation, which is usually an hour, not 20 minutes, that I push on with companies that I wanted to share with you, because if the answers to these aren't good, it's a no for sure. So first, is the unmet need big enough? As you can tell, I don't want to do a little incremental 5% better. Is this big enough to matter? Like if we kick ass and surprise people by our success, have we made American healthcare different? Are people going to notice this company? If you can't sort of get to an answer that gets you pretty tingly about that, probably not looking at a good enough idea. Is there a hard ROI? Not touchy-feely, 5 years from now you're going to live more self-actualized, although I'd like that too. But no. How much money does this save the person who buys it next year? Okay, and then what about the year after? That's sort of question one. And it better be like mathematical. It can't be sort of like hope and prayer. It needs to be like, point it out to me. Show me the arbitrage. Show me what are we spending today, what will we spend if we use your product, and there needs to be a real answer to that question. It can't be soft. If it is soft, there isn't one. Because there's so much money in our system and we waste so much of it. If you can't find like a couple dollars of real value, it's not going to be good. This one's super important and it's often missed. So whose money was it? So every dollar you save was somebody's revenue and somebody's profit. So you need to then figure out, where did you just take that money from? If it's the customer who bought it, you're probably screwed. Most companies that are kind of thinking about hospital things often come and say, we save a lot of money, and then it's like the hospital's money. So the hospital's not psyched about it. A lot of readmissions reductions programs have really bad economics for the hospital if the hospital's not full. So you need to figure that out. And by the way, even if it's not the money of like the customer, if it's like the customer's best friend, that's also an issue. Or if they have really great IP, really great lawyers, or they're really, really big. So be aware of like who you're going to piss off. Because they will actually, respond when they begin seeing the innovation that you're bringing to the market. And I can't tell you how many entrepreneurs get that question wrong. Like they haven't thought of, and then they have the epiphany of like, oh, okay, it may not be all good. The fourth one is really important and often not done quite right in healthcare businesses, but what network effect are you building? How do you create barriers to entry? Hardly anything that you'll invest in has IP protection and can't be copied. So how do you create a barrier by virtue of each user makes you smarter about the next user? How do you build that? And there's lots of ways to do it through patterns of behavior of people using the product, of reviews or data that they give you, or but that's very important to think through. How do you build a network effect? If you can't build one and the idea doesn't suck, you should think that there'll be 10 more people doing it. And so then you're going to have a lot of competition and break up a market. So how do you build this, and what does it look like, and when do you get it? Do you have to get to 30 million users to have that effect, or can it be like 5 big systems? I mean, that's important to think through. And the fifth one, and this is a big deal in healthcare, because it's healthcare despite the fact that like CPMC is probably hospital systems can have a few $1 billion of revenue. Almost all these things are relatively small and medium-sized businesses. And so how do you reach them? You don't want to have to spend $100 million in a sales force for an idea that's a $100 product. How do you reach the market? Virality in healthcare has been really, really hard to find and create. It's almost always a B2B2C or some sort of semi-enterprise play. How do you do this? Channel partners, you should have a kind of a jaded look about because they tend not to sell the other product as much as their own. So how do you do this efficiently? If you can answer these 5 questions, though, it's worth having another 2 hours of thinking, probably. But that brings me to regulation. I love this picture because I think it's important yet ironic. This is Columbus Children's Hospital, 1962. This is the first electronic health record we had in America. They used it to actually look at patient allergies and medications to find medication errors. And what they proved definitively in a peer-reviewed study in 1962 is that this really saves lives, and it's a really good idea. The whole EHR should happen. And 50 years later, we have begun to do this at scale, and we're beginning to see real adoption of EHRs. Like all things in healthcare, it takes longer than you think. But what's important to point out is that regulations matter here. And there's 3 types of regulation that you should be thinking about in any company kind of as a checklist. And the first one is, okay, is this thing FDA regulated? If so, don't screw around. Make sure that they follow the rules. The FDA rules are incredibly transparent as to what has to happen. The FDA website is a treasure trove of detail about what is required, and thou shalt not break that rule. So be aware. Most of the things that you're going to look at are not going to be FDA regulated. Some of them will require FDA registry. So if you're doing some of the medical apps and products that you may invest in, they might require the company to submit to FDA documentation that they exist in sort of what they do, but the company should follow that. The second kind of federal level regulation is, are there CMS rules, Medicare rules that are important? Broadly speaking, if your company requires CMS reimbursement code changes to happen, you should sort of assume that's not going to happen. But understand, what are the CMS rules and regulations about this? Relevant rules include the Stark laws, the corporate practice of medicine laws, the anti-kickback laws are sort of the three that you'll most often have to think through. Does this have any bearing on the business model of the company? If it does, I probably wouldn't invest angel money in it. I would wait toward lawyers and A-round investors to sort it out if that's going to happen. The third level is state. So an unbelievable amount of health care is actually governed, much to my chagrin as a federal policymaker, by state laws that we couldn't supersede. And so states are the ones who decide what is an insurance plan, what is required, what is the scope of practice and who can do it, who can own different types of facilities, and obviously they govern the Medicaid programs and the changes in their state. And so those are the three spots where you need to look. My broad feeling that I'd want you to take away is that in general, for the things that you're going to see, regulations don't matter. The general bias towards regulators is to support things in the health system that are going to lead towards either cost savings or substantial improvements in quality. And in general, I think the tone of regulators towards health innovation is one of let it happen. That said, you were making a tragic error if you haven't thought about it and you haven't asked the entrepreneur what their plan is, and they should have thought about it. I would then say a device needs FDA, like it's a mobile health device that needs FDA approval. Okay, it's going to take about 6 months, $4,000 sort of total cost. These aren't like insurmountable. This is not a new drug, but you shouldn't sort of just assume that there's nothing to do here. Let me end with the following. Here's what you should do. This is kind of back to what Ash said about, you need to do this because you love it, not because this is your primary investment strategy. If it is, you are crazy. So the first thing is that the best part of this job is you can help exceptional people do things they couldn't imagine and do it faster than they thought and do things that is life-changing for them because they are so proud of it, and you are proud of it too because you helped it happen. That is the joy that you should get out of this job. And you shouldn't think about it as 10 years later realized joy. You should love every day that you help an entrepreneur, like not have more pain and solve a problem or celebrate the small victories. That's the best part of this, which is why you should like them and they should like you, and that's what you need to do this for. And all of you have been wildly successful to be able to have enough money to blow doing angel investing. So you know what? You all have great advice to offer. You've all gone through tribulations. You can commiserate, but you should do everything you humanly can to make your entrepreneurs happier, more energetic, more joyful, have better talent, solve problems, have less pain, and be with them when it's hard, and be with them and hug them when it's happy. But that's the first thing. Which brings me to point 2. I tell entrepreneurs, why on earth are you taking money from these people unless they're all giving you something valuable you don't have? Because I have plenty of money. I can go fund stuff, right? We only want angels and deals when you do stuff that's useful. So for Christ's sake, think about what you're going to do that's useful and do it, and deliver for that to the entrepreneur. That's why you should be there. You should be helping them meaningfully accelerate growth and goodness in their company. The third thing is you all know freaky, smart, talented people and friends that know more than you do. So you should help that company tap into those networks. Super valuable. The hardest thing to do in an early stage company is find the next 5 great employees. So you should help interview people, source them, tap into your networks, help get good talent. Talent almost always wins. I promise whatever idea they pitched, which is why Ash said don't spend so much time on it, it's totally wrong. It's only at best directionally correct. It will pivot 17 times. And that's for our really good home runs in our portfolio. I mean, Castlight Health was not that exactly. Athena Health was an OB-GYN management company in San Diego, and it was a terrible investment until it became a good one. So, you need to help them get smarter people to pivot faster than the other people. So it's a talent game. Use your networks, and for Christ's sake, do real work. Don't ask for email updates and phone calls for that's just a total waste of everybody's time. You should not need to get updates because you're actually engaged. And if you're not going to do that, go buy a T-bill. I mean, you should be doing real valuable work. So with that, let me stop and thank you, and I hope that I hope you take away, this is super fun. Healthcare is changing faster than it ever has before. You will get great joy from making that happen better. And for Christ's sake, if you're going to do it, roll up your sleeves and be helpful. So let me stop there and invite your questions.